Thank you. So just to give you a little bit of background, the talk will focus on rheumatic diseases, but it will predominantly focus on rheumatoid arthritis. So rheumatoid arthritis, you might be more familiar with osteoarthritis, which is the wear and tear arthritis that predominantly affects older people. Rheumatoid is an autoimmune condition. It's characterized by swollen joints, stiff joints, speak up, sorry. Patients also can experience joint damage. So you see there the traditional arthritic hands. They experience pain and fatigue, and their symptoms can fluctuate on a daily basis. It affects around 1% of the population. There's no cure. And unlike osteoarthritis, which affects older people, the peak age of onset is around 35 to 50 years. The majority of these patients are female, and there is higher pain and disability reported in women. But we think this is highly likely, this is another whole separate talk, but we think it's highly likely that that's due to measurement bias issues. So the measures that we use have been developed in a population that reflects the RA population, which is predominantly female. The literature suggests that men do take longer to adjust and adapt to their condition. And my PhD work, which didn't particularly aim to focus on gender, but we unexpectedly found that men were struggling to cope with their condition, but they weren't interested in the support that we're providing in rheumatology. So my postdoc went on to focus on men, masculinity, and rheumatoid arthritis. So I started with a scoping systematic literature review to find out what's known about how men cope. And in fact, only 2 small qualitative studies had ever been conducted. And both of these were master's projects that had never been taken any further. So we were interested in the impact of RA on men and their preferences for support. So I conducted focus groups with follow-up interviews. And I followed them up with interviews for the men that we felt that their stories weren't especially heard in the focus groups. So just a very brief summary of those findings. These data are published. So we found it was really important for men to maintain their masculine roles and identity despite having the condition. They used a range of coping strategies. Some of those strategies could be destructive. When, for example, many of the men, to cope with the emotions attached to the condition, would do things like they'd over-exercise. So I'll run and run until I can't run anymore. And this was potentially, well, it was causing them more pain and potentially further joint damage. They hadn't found another outlet. They were well supported by their wives if they had them, but they said their friends weren't supportive. They didn't want to listen if they talked about it, so they didn't talk about it. And they tended to prefer practical rather than emotional support. So we were interested in whether there are groups of men with rheumatoid arthritis who have similar experiences and coping styles to each other. So we used Q methodology, which is a form of consensus technique, but it manages to retain individual differences. So due to the time, I'm only going to explain the method sufficiently for you to understand the findings. So it used qualitative and quantitative techniques. And it involves asking participants to sort statements of opinion. And we took 64 statements about their experience of RA from the literature review and our qualitative work. And I asked patients to sort these across a normal distribution grid, which I'll show you in a moment. And then I interviewed them about the way in which they'd sorted the statements and their reasons for that. So this is what the grid looks like. As you can see, horizontally, they're sorting from least like me to most like me. And then vertically, the statements can be equal to each other. So they get the least number of statements in the extreme views, and then the majority are in the neutral slots. So Q methodology involves a reversed form of traditional factor analysis. So the participants themselves form the variables, form the factors, sorry. So factor A, so we had 30 participants, which is a standard Q methodology sample. In factor A, this consisted of 14 of our participants, and factor B consisted of 8. They were similarly matched for age and disease duration, but it's particularly notable that those in factor A had a much lower HAQ score, that's the Health Assessment Questionnaire, which measures disability, that's scored from 0 to 3, whereas those in factor B had a much higher level of disability. Also, in factor B, many more were taking our most aggressive biologic therapy drugs. 5 had an opinion that sat in between the two, and 3 sat outside of the two-factor solution, but this was the most inclusive solution that we could find. So for brevity, the summary of these two groups, those in factor A focused on the positives in their life, the positives of their condition. They found ways of adapting, different ways of doing the things that they used to, or new activities to replace those they'd lost. They kept active as much as they could. They felt able to ask for help from friends, family, from their medical team. And these patients felt they were able to retain their independence and their control. Interestingly, many of these men were in positions that enabled them to do that. So they were either retired, or they often worked in jobs that allowed them to take time off when they needed to for their condition. They said that they don't get angry or aggressive because of their condition. By contrast, those in factor B highly prioritized frustration and anger because of their condition. But they internalized this. They didn't get angry with their friends and family. They were angry with themselves. They felt guilty about the impact their condition had on the people around them, their friends, their family, particularly if they had a young family. They tried to do everything exactly as they had done before they were diagnosed. They didn't want to adapt to their condition. They wanted to be normal. They wanted the normality they used to have. They didn't ask for help from friends, from family, from strangers. And they didn't want to use tools, devices, gadgets, things like walking sticks or aids to help them. And they really felt a loss of independence and control due to their condition. So in summary, we named those in factor A, acknowledge, accept, and adapt. And there's a quote from one of the interviews, "It's far easier to cope with it if you accept it." However, those in factor B, we felt were struggling to match up to their own ideal of what it means to be a real man. And this quote really typified this group of men. "I don't talk to my friends about it. They'd think I'd gone soft if I did. Men don't cry. You know this, don't you? No, we don't. Not in front of anybody. You never would." And I think it's highly likely that we're under-recruiting these patients. So they were the smaller group, but these are likely to be the very men that wouldn't want to take part in face-to-face research. So we'd conducted a scoping review, qualitative work, and a consensus method. And then we were interested in how widespread these impact and coping strategies were across a wider population of men with RA. So I sent a postal survey to men across England. I won't dwell on this slide due to time, but we received nearly 300 responses. We were fairly happy with nearly 50% response rate for men. Again, I won't dwell on this slide, but this tends to reflect the population and RA population. It's probably worth noting that around 25% were considered either a case or borderline case for both anxiety and depression, according to the Hospital Anxiety and Depression Scale. So in order to see whether these Q methodology factors could be identified in a wider population, so we did have some lack of response, unfinished questions, so we ended up with 280 included in this. We asked men to complete numerical rating scales for the statements that particularly distinguished the two factors from each other. We conducted a traditional factor analysis to check that the statements we'd picked did map back onto our factors. And then we assigned each participant to either factor A or B using a weighted averaging of their scores, or if there was insufficient difference between the scores, then they were unassigned to either group. So notably, in the Q methodology study, the majority were loading onto factor A. But as I said, we were under-recruiting these participants, and now we had, in the wider population, the majority were falling under factor B, the struggling to match up category. Again, I think it's still likely that even in this study, we're still under-recruiting these men. And notably, we had a similar percentage unassigned to either group, which we feel validates our study. So just to focus on demographic data, there was very little difference between the two groups, although there was a significant difference in employment, with those in factor A being more likely to be retired and those in factor B more likely to be unemployed due to their condition. In terms of disease status, though, those in factor B had much more severe disease. They were significantly higher on the patient global assessment, so considering all the ways your disease affects you, how do you feel today, on disability and on their perceived disease activity. Significantly more of those patients were also taking our most aggressive biologic therapies. Again, in terms of coping, those in factor B scored significantly higher on all types of coping that we measured, so confrontation, avoidance, and resignation coping. However, those in factor A scored significantly higher on their acceptance of illness. In terms of psychological status, there's a clear difference. Significantly more men in factor B reported depression and anxiety and perceived stress, and in fact, nearly 50% of these participants were either a case or borderline case for anxiety and depression, whereas those in factor A were scoring significantly better on mental well-being. So we were also interested in their preferences for support. We wanted to see whether there was a difference between the two groups of men, but also we know that when it comes to commissioning NHS services, we'll be asked, is this different to women? So we also sent just the support component of the survey to women. So we gave them a number of options for support taken from the literature across all long-term conditions, as well as suggestions from the focus groups. Their top preference was a website for information. They weren't particularly interested in discussion boards or chat rooms. They were also interested in a question and answer session with their consultant, and this was a suggestion from the focus groups. They were also interested in an organised talk about current research, which again was a suggestion that came from the focus groups. They wanted education on managing their physical symptoms or a question and answer session with their specialist nurse. This actually doesn't differ that much from what women wanted. So interestingly, the main type of support that we offer are support groups, and this didn't make it into women's top 5 either, although women were more interested in men in hearing from lifestyle experts how to manage their diet, etc., associated with their condition. So when we look at the differences between the two groups, again, interestingly, there was very little difference in terms of their preference for support, although those in factor B, so remember those are the more, those that were struggling or had poorer psychological outcomes, they were significantly more likely to select education on managing their physical symptoms, and this actually didn't even make it in to the top 5 for factor A. So considering those in factor B are the ones that are struggling, it would still be really important to include this, even though it doesn't interest this group of men. In terms of practical issues, the majority were interested in support that they could just come and go as they pleased with an advertised timetable and not a fixed commitment. Many of them wanted to be able to fit this around work or other commitments. And often the type of support we provide is a 6-week program, perhaps with a later follow-up. That didn't suit men. Interestingly, the majority also had no preference of group gender. We think that there might be an element of this that's social response bias, perhaps, because it's not really acceptable for men to say we don't want women in our group. But also it may be that they haven't possibly thought through the implications of the difference between the two groups. So when I said to men, would you mind if this group was a mixed group, most of them said, no, we'd be happy, we'd like to hear what women have to say. When I said, would you have talked about the same things as you talked about today if women were in the room, most of them said no. And this is a quote from the focus groups, which perhaps explains why it can be difficult for men to open up in a mixed group. And although it's possibly a slightly jarring quote for women to read, I think probably a lot of you can perhaps relate to that, particularly when you're looking at a population of women of a certain age. So at least 43%, and I say at least because I really do think that we're under-recruiting these men, have severe disease, poor coping, and poor psychological status. Now, it's important to note we don't know the cause and effect here, so of course those with more severe disease are probably going to struggle to cope. But we do know from the literature that baseline and persistent symptoms of depression and anxiety are associated with poorer health outcomes and reduced treatment response. So if we're doing the most that we can physically for these patients, most of them are on our most aggressive therapies, we need to be looking at how to support them psychologically. Women were more likely to report intention to attend all of the options more than men, which supports the literature that women will try more things and men will be more picky, but once you've got men into an intervention, they're more likely to stay than women. And again, as I said, the majority reported no preference for group gender, but we know from other conditions like obesity that when you stratify by gender, male groups do differ to female groups in terms of engagement, language, and success. Men tended to prefer practical rather than emotional support, which supports the idea that men use information exchange as a form of emotional support. There was little difference between the two groups in terms of preferences, so it's likely we could provide the same support for all men with this condition. But when it comes to commissioning, it's difficult. The more that you stratify, and of course less men experience this than women, the more you stratify, if we stratify by gender, the numbers that we're serving reduce. So we're aiming to see whether we can provide an intervention across rheumatic diseases rather than just in RA. So I'm now focusing on systemic sclerosis, which is another rheumatic disease. It's another autoimmune condition. But this is a collagen vascular disorder. This causes inflamed blood vessels, restricted blood flow, and it affects collagen production. The limited version, it only affects the extremities, so the hands and feet. But you can see that is severe impact on the hands. That's produced by experiencing cold due to the blood flow to the extremities. They can experience digital ulcers, which cause shrinkage of their digits. But the diffuse version is the more severe version, and this is an all-over body experience, so you can get the disfiguring on the face. You can see the lack of collagen production there, causing the tightening of the mouth, and you do get organ involvement. It's a rare condition, so for about 1 million people, 20 people might be diagnosed with this, and there's no cure. Again, it affects predominantly women. Men have significantly reduced survival rates than women, and men report more severe disease than women. We conducted a systematic literature review and found that such studies that focus on psychosocial gender differences don't include enough male patients to look at the differences. And despite men dying at twice the rate of women with this condition, no studies have ever focused solely on men. So I've started. I'm still waiting for NHS ethics for my UK data collection, but I've conducted 3 focus groups in the US. Probably the most notable point on that slide is that the majority had the more severe version of this condition. I'd just like to highlight these unpublished data. The data collection is still ongoing, so this is very much the preliminary findings now. So I've just pulled out some of the key issues. So one of the most important things that men said, when I said to them, what do you miss about since being diagnosed? One of the first things they said was, I miss sex. So due to the lack of blood flow, many of these men experience erectile dysfunction. It has an impact on their relationships, and it has an impact on the way they see themselves. I've got a spouse who is very understanding. I had that going for me, but it doesn't matter at the time. As a guy, I've got a problem. Personally, I thought I had a serious problem, and that affects you as a guy. In terms of support, though, their clinicians don't mention this. They had to figure it out for themselves. They weren't told when they were diagnosed that this was a symptom, and it's never, ever been brought up in their clinical practice. But when I asked them, would you talk about this if your clinician brought it up, they said, yes, of course we would. But they have to bring it up first because this is embarrassing. They were worried about their mortality. They were constantly worried about how long they had left to live. Many of them in my focus groups had experienced, had lung transplants. They were worried about the impact of the things they were going to miss out on with their family, with their children. And for anybody who says that men don't cry, there wasn't a dry eye in that focus group when that man was talking about what he'll miss being able to do with his daughter.
They also planned for the future, quite practically planned for the future. They wanted to make sure their wives were able to continue to do the things that they currently do for them in case they're no longer around. They were concerned about their loss of work. Many of them had had to take early retirement due to their condition. And I've only provided one quote to illustrate this, but I think it really shows the impact of the loss of that breadwinner role. It's not a pity party. I'm not trying to feel sorry for myself. I ask myself, what am I here for? Sorry, did you want a photo of that? And then finally, in terms of accepting help, many of them didn't have the option. In rheumatoid arthritis, they rejected help, they struggled through. These patients didn't have the choice, but the impact of that was really difficult for them. Do you know how hard it is to have your wife put your socks, your shoes, your underwear on? So they'd often make jokes, or they would put themselves down. I turned in my man card, open this for me. Or they'd brush it off. I want to stick around. You drill that hole. You climb that ladder. I don't care what you think of me, whatever. Just one more. So in terms of talking to others, they really didn't. They didn't want to talk about their condition. They tended to only talk to their wives or their doctor. And I think this quote's particularly poignant just to show the level of responsibility that they felt they had in the home. I want to tell people I'm sick, but I don't share it with my wife or my mum. I'm the breadwinner. I've got to try and stay positive and focused for as long as I can. They're depending on me. So to summarize, they had a severe impact on their masculinity. They had lost their breadwinner role. They had to accept help. Erectile dysfunction was a key concern that health professionals aren't talking about. There's a real argument for male-only support here because they wouldn't have talked about the erectile dysfunction issue in a mixed group. They told me that. There's also an argument for disease or severity stratified support because, again, it's potentially difficult for these men to open up about something like erectile dysfunction in a group of men that don't experience this. So our next steps are to continue data collection with this condition and also to move forward in developing an intervention, possibly with key core components across the rheumatic diseases, but stratified for issues that may be are less appropriate to share. So there's my acknowledgements. Thank you to my funders, my steering group, and of course, the men that participated.